Good afternoon, everybody. So after that brilliant presentation on diabetes emergencies, I know most of you must be hypoglycemic now. So I'll bear that in mind. So anyway, this is the final presentation. So all of us who are born in this world, we are gradually moving towards this ultimate reality, whether we like it or not. But unfortunately, in patients with diabetes, they meet their end much earlier than those who don't have diabetes. So the question is, what is the main reason for this? So if you look at evidence, patients with diabetes, they tend to lose around 7 to 8 years of their lifespan. So the main reason for early death in patients with diabetes is atherosclerotic cardiovascular disease. Therefore, we have to see how we could mitigate this risk of atherosclerotic cardiovascular disease in patients with diabetes. So it is in this context I am talking about diabetes therapeutics and cardiovascular outcome. So all this time the speakers use diabetes therapeutics to see how we can control sugar. But now the question is how we use them to control cardiovascular disease. So the outline of my presentation would be as follows: the modern drugs and the cardiovascular outcome trials, and what is the real world scenario, and how guidelines have changed based on this new evidence, and the local scenario, how we take this information and use it on our patients. So I will be mainly talking about two groups of drugs. These are modern drugs, SGLT2 inhibitors and GLP-1 receptor agonists. So as you all know, if they are anti-diabetic drugs, the main reason for developing them is to control sugar. So if someone asks whether these drugs can reduce cardiovascular disease, it is like asking a fish to climb a tree, because the drug was actually produced to reduce sugar. So the whole story started with this gentleman called Nissen. He's a cardiologist by profession. In 2007, in a research he showed all those who were taking rosiglitazone, which was a very potent hypoglycemic agent, quite a number of patients developed myocardial infarction and death. So if a drug controls sugar and in the meantime, if it is causing early death, then there's no point in giving that drug. It's like telling operation successful, patient died. So then it sort of took the scientific world by surprise. And then the following year, the FDA came up with this new mandate. It was a knee-jerk reaction. They said all anti-hyperglycemic agents should have proven cardiovascular safety prior to marketing. Otherwise, you are reducing sugar and killing patients. So then they said you have to come up with randomized controlled trials, and in that trial you have to prove that the new drug is not inferior to placebo in terms of reducing cardiovascular disease. So to identify the cardiovascular disease, they had three criteria. This is called the 3-point maze. So there's cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. So these are the endpoints. And in some other studies, they were given the option of adding heart failure and then the incidence of revascularization. So this new mandate made every new anti-hyperglycemic agent to undergo this trial to establish cardiovascular safety. So the drugs that had to cross this additional burden were DPP-4 inhibitors, GLP-1 receptor analogs, and SGLT2 inhibitors. Because when you develop a drug, you have phase 1, phase 2, phase 3 trials. Here, after those 3 trials, you have to cross this burden of cardiovascular safety as well. So that is why after 2008, people are talking about so many cardiovascular outcome trials. So that's why if you want to get through your exam, you have to get through the exam very early. Otherwise, you have to learn more cardiovascular outcome trials, right? The candidates. So here, basically, what we had to show was the hazard ratio for that particular drug in terms of cardiovascular disease was not more than 1.3 compared to placebo. But the drug companies were very smart. They used the same study, because they're spending a lot of money and time. They used the same this thing to also see whether the hazard ratio is less than 1. So if you prove that the hazard ratio is less than 1, you are not only saying that it is safe, you're also saying it is superior in terms of reducing cardiovascular disease. So that's how this story came about. So the drugs, I'm going to talk about SGLT2 inhibitor and GLP-1. So SGLT2 inhibitors, you know how it works. Dr. Nanju have told you. So it causes glycosuria. So the common drugs are EMPA, CANA, and DAPA. So the first cardiovascular outcome trial was EMPA-REG study. So it was carried out in 42 countries, 590 sites, and our endocrine unit in Kandy, we were also part of this study, and we contributed 4 patients to this study. So then when we looked at the outcome, it was surprising because the hazard ratio was 0.86 for cardiovascular disease. So that means it is not only controlling sugar, it is reducing cardiovascular disease. So then all of us were really excited and happy to see that. And when we looked at heart failure, which was another endpoint that we spoke about, the hazard ratio is 0.6. So then it has a very sort of pronounced effect on heart failure. So then the question was whether it was a single drug or the whole group. So then EMPA and canagliflozin, they reduced the 3-point MACE, but dapagliflozin, it failed to reduce the 3-point MACE. That means it's safe, but it didn't have a superior effect. So then if you look at the type of patient that they have taken in, so these are cardiovascular outcome trials, the last stage. So the drug companies will not want to prolong the study. So they will want to reduce the time period. So for that, you need more cardiovascular events. Then only you can analyze. So in order to get more cardiovascular events, you have to take high-risk patients. So then the first 2 trials, if you look EMPA and CANA, the number of patients with cardiovascular disease, EMPA was 100%. But CANVAS study, it was 65%. These are patients with established cardiovascular disease. So then the rate of death is high in them. But if you look at dapagliflozin, only 40% had established cardiovascular disease. So then that's why you didn't see a difference. So again, so this is the forest plot, how to interpret it. So the middle line is called the null effect line. So if the confidence interval crosses the null effect, that means it's not significant. If it doesn't cross the line, that means it is significant, because I'm also not very good at statistics. So I had to remind myself rather than reminding you all, because I know you all know how to interpret it. Right. So now here there's an interesting thing. They looked at all the patients in this study, 3 studies, and looked at them with atherosclerotic cardiovascular disease, and the others who did not have atherosclerotic cardiovascular disease but who had high risk. So then if you had established atherosclerotic cardiovascular disease, then there was benefit with SGLT2 inhibitor. If you did not have established cardiovascular disease, then there was no benefit with SGLT2 inhibitor. These are the cardiovascular outcome trial results. So then, as I told you, there was 0.8, the hazard ratio was 0.8 with regard to cardiovascular disease. But when it came to heart failure, it was 0.6. So that means all 3 drugs as a class, they have a very good effect on heart failure. So bottom line is, with regard to 3-point MACE, there's a positive outcome with SGLT2 inhibitor treatment, but they have a strongly positive effect on heart failure. So next is GLP-1 receptor agonists. So how they work, already the previous speakers would have spoken to you. So then these drugs, there are drugs which are similar to the GLP-1 that is being secreted in our body. So these drugs also, liraglutide, semaglutide, and dulaglutide. These are the commonly prescribed drugs, and in Sri Lanka we have liraglutide and dulaglutide. So then these drugs also, they had a significant positive effect on 3-point MACE. So then they had a significant cardiovascular outcome. But there are some other drugs which did not show, but the commonly prescribed ones are good. So then they reduce cardiovascular disease. But with regard to heart failure, the blue color squares here, they represent GLP-1 receptor agonists. The red color squares, they represent SGLT2 inhibitors. You know SGLT2 inhibitors have a very good effect. So this line, it demarcates. So GLP-1 receptor agonists, they are on either side of that null effect line. So then they have minimal or no effect on heart failure. But if you carefully look at this, there's a small red blue rectangle there, right? So then that seems to be better than even SGLT2 inhibitors. So that is in this amplitude study. So then there is a new latest GLP-1 receptor agonist, which seems to have a very pronounced effect on heart failure. So we have to wait and see as to how it happened. But 15% of those patients in that trial, they were also on SGLT2 inhibitors. But according to results, even without that, if you exclude that also, there's a good effect. So time to come, the new SGLT2 inhibitors are going to be very good. So then the issue is cost. So it costs around 50,000 a month. So there are patients even in Kandy who are taking that. So most of them are either politicians or related to politicians. But some of my good colleagues are also on it, right? So then there's this new drug called tirzepatide. So this is a combined drug. It has GLP-1 and GIP, both effects. So this is called a twin creatine. So then this seems to be a wonder drug. The HbA1c reduction is 2.4%. So that means it's a really good reduction, significant reduction. And the body weight is reduced by 11.3 kilograms. It is like Chaturanga doing bariatric surgery, right? So then almost the same effect. And then, but bariatric surgery is a little more than that, but it's in that line. So then the efficacy is superior to the current GLP-1 receptor agonist. So the cardiovascular outcome trial of this particular drug is awaited. The results will be released in 2024, but it will come as a treatment for obesity, non-alcoholic fatty liver disease, and type 2 diabetes. So with regard to 3-point MACE, GLP-1 receptor agonists have a positive outcome, but as a treatment for heart failure, they are not that good. Tirzepatide, we have to wait for the outcome trial. So then, although I spoke about cardiovascular outcome trials, if you look at the inclusion criteria for these patients, only about 40% of our patients who come to our clinic will really fit into these inclusion criteria. So then can we generalize this to all the patients who are coming to our clinic? We can't. So that's why you need real world studies. So then they have to give it for normal patients who come to the clinic with diabetes, and they see what kind of disease. So here I'll just cut it short. In real world studies, they clearly showed that it has primary prevention effect as well as secondary prevention effect with regard to cardiovascular disease. GLP-1 receptor agonists as well as SGLT2 inhibitors. So how they work, you all would have heard about it. So the bottom line is real world studies clearly show that SGLT2 inhibitors and GLP-1 receptor agonists could be given as primary prevention of cardiovascular disease and as secondary prevention of cardiovascular disease. So then how the guidelines have changed in according to the latest guideline, what they say is first thing that you ask when you see patients with diabetes is this patient having a higher risk of cardiovascular renal disease? Earlier we looked at the sugar. Now first question that we ask is there a higher risk of cardiovascular renal disease? If there is established cardiovascular disease, or if there is a high risk of cardiovascular disease, someone over 55 years who also has other risk factors for cardiovascular disease, then first thing you would consider is GLP-1 receptor agonists or SGLT2 inhibitors. And if they have heart failure, definitely SGLT2 inhibitors. Then only you will look at the rest of the things. So then it's a paradigm shift. Earlier at the beginning, our main focus is how to control fasting blood sugar, how to control postprandial blood sugar. Later in 2008, we said you can control sugar, but make sure that you don't kill the patient by causing cardiac disease. But now we have come to a stage where it's called vascular glucocentric approach, where we are giving medication for diabetes in order to reduce cardiovascular disease. So the whole paradigm has changed. So this is called the cardiometabolomic era. Now the first line drug is traditionally metformin because of its efficacy, minimal risk of hypoglycemia, effect on weight, safety, and low cost. So all of you must be familiar with these kind of slogans. I have not put the full thing. Like that, there is another slogan called metformin go home. So this metformin go home, they are trying to kick metformin out of its prime place of first line treatment for diabetes. But if you look at the guideline in 2018, ADA, EASD, this is the American European combined listing. So that is what we all follow. So in 2018, they said metformin is the first line drug. After that only you will be considering SGLT2 and GLP-1. But the cardiologists in 2019, European Society of Cardiology, they said if someone is metformin naive, someone who has not been started on any treatment for diabetes, And if that person has cardiovascular disease, bypass metformin and straight away go for SGLT2 inhibitor or GLP-1 receptor agonist. But ADA was sticking to metformin. But the following year, now in 2022, even ADA they have changed their stance and they say, first thing, if they have cardiovascular disease, straight away think of SGLT2 or GLP-1 receptor agonist. So then my trainer at Oxford, Professor David Matthews, was one of these authors, so I had an email chat with him. So what he says is, only a small proportion of our patients are going to actually have cardiovascular disease. So this is to emphasize the fact, if someone has cardiovascular disease, give drugs which reduce the risk of cardiovascular events. But majority of our patients are anyway not going to have this risk. So then metformin is going to be the first line drug for most of our patients. But if someone has this, then you're going to think of SGLT2 inhibitors. But can we just kick out metformin without a head-to-head trial? Because so far they have to directly compare these drugs with metformin. That has not happened. So therefore, it is questionable because metformin is an orphan drug. No company is marketing it. So there is no pharma support to promote metformin. So you have to keep that also in mind. So our local scenario, these drugs are quite expensive. So this is where we are now. Okay. So then what do? So we have to see whether there are cheaper drugs, and our drugs like metformin, sulfonylurea and pioglitazone, whether they can reduce cardiovascular events. And then by intensive glycemic control, whether we can reduce cardiovascular events. So then when we look at it, there's a good meta-analysis where they looked at all the drugs that are available and their cardiovascular disease, but there should be a good quality trial. Then only they included it to the study. So sulfonylurea, if it's green, that means it's neutral on cardiovascular events. And then next is pioglitazone. That is also neutral, but if someone has heart failure, it could be harmful. That is the blue box there. But metformin is not here in this study because we don't have a single metformin study which can be classified as a good quality study. So therefore, it is our role to make sure that we do a metformin related study. So then the only study that we generally quote is UKPDS trial. In that metformin arm, the cardiovascular disease was less. So then, but it's only 700 patients. There are other studies, 300, 200. So we have to do, as a developing country, we have to spend on these kind of trials so we can see. So then in other cardiovascular outcome trials also, those who were on metformin, they fared better than those who were not on metformin, even with the modern drugs. So therefore, there is enough room to believe that metformin has some amount of cardiovascular benefit. So then there is positive outcome, but the evidence is not strong. But what you should remember is, in archaeology, what they say is, absence of evidence is not evidence of absence. So just because we don't have evidence to say that metformin is not good, that does not mean we can forget about it. Next question is intensive glycemic control, whether that will bring about cardiovascular benefit. In UKPDS trial, initial this thing, there was microvascular benefit, there was no macrovascular benefit. Cardiovascular disease did not come down. But when we follow those patients after 10 years, that's called the legacy effect. At that time, they showed if you had treated them early very well, there was reduction in cardiovascular events. So then you have to catch these patients with diabetes early and then treat them aggressively at the beginning. Then there will be cardiovascular benefits. So that's a cheaper way of achieving this. So intensive glycemic control may have positive effect on cardiovascular outcome, but again the evidence is not strong. So this is the last slide. So the take-home message, when we manage patients with diabetes, our main goal is not to reduce sugar, but to minimize cardiorenal disease. So then SGLT2 inhibitors and GLP-1 receptor agonists have significant cardiovascular outcome benefit, and especially in those with established cardiovascular disease. And SGLT2 inhibitors are beneficial in heart failure, but we should not underestimate the potential of metformin and early and aggressive treatment of diabetes, especially considering the Sri Lankan economic context. Thank you.
If you have any questions, ask. It's the time to ask. I think we have a panel of speakers, so it's a very important topic. for me that it can reduce some of the cancers. Is it true? What cancers?
The question is whether metformin can reduce cancers. Yes, because it acts through a pathway called the mTOR pathway. So oncologists also use that very much. And then using that pathway, they have shown that it reduces the incidence, but in a not a major clinical disease. But if I remember correct, pulmonary, GI, and some other prostate, I'm not exactly sure maybe. So therefore, it has some benefit, but it's not very significant. But still, it has because it acts through the mTOR pathway. And the same mTOR pathway also reduces aging process also. Now, in nematodes, they have shown that the same pathway could be used to retard the aging in nematodes. And now there are newer drugs which people are trying to develop in order to reduce aging. So now when there is a lot of myths about metformin saying that it can cause renal failure, these are some of the facts that you can present to your patients to encourage them to take metformin. Thanks, Charles, for excellent lecture. My question is, you talk about the legacy effect of the insulin. In the one-time verification, the newly diagnosed diabetes, like in Dr. Kaldasi's first case, 45-year-old banker who is coming with a bit of a hyperglycemia without any metabolic complication. So the concept of this very the legacy effect of insulin, you start the insulin, so the patient has not much of the metabolic habits. Their outcome is much better. Their future control is much easier with oral antibiotics. What is your opinion when a newly diagnosed patient with hypoglycemia without any metabolic complications starting on insulin? Yes, so when patients come, our main thing is to make sure that we retain the potential of the beta cells to secrete insulin. So then, in that context, people are talking about this legacy effect. But the issue is insulin, the prime this thing is insulin resistance. So therefore, targeting that will have a great effect on other body organs like microalbuminuria and fatty liver disease and things like that. So now there's another trial called Verify trial where they have used metformin and vildagliptin, and they have shown that kind of a like, prolongation of this beta cell effect could be brought about by that. Uh, and the other legacy effect that they talk about is whatever the way in which if you control the sugar very well at the beginning, then the final end result that we want is reduction of cardiovascular disease that could be achieved by very tight control. So, but all these are like theoretical possibilities. But I feel starting insulin at the first line at the beginning itself for legacy effect is not a practical thing that we could do. Charles, what is the place for giving IV bolus in an emergency situation to control blood sugar? Generally, we don't give IV bolus because that IV bolus it remains in the circulation only for 5 minutes. So therefore, you have to some guidelines they say you can give an IV bolus and continue that with an infusion. So other than that, just giving an IV bolus, I don't think it has any effect. So unless you follow it up with the infusion. Nishan, have you got any answer? It's there in some guidelines. Some guidelines also they say to give 0.14 units per kilogram bolus followed by an infusion, not just the bolus and then wait for the blood sugar to come down. Other guidelines they go with zero point 0.1 units per kilogram, but in pediatric patients they are still going with the infusion. In adult patients we can go for 0.14 units per kilogram bolus followed by zero point 0.1 units per kilogram per hour infusion, not in pediatric population but in adult population, not just the bolus.
that comes to the conclusion of this, symposium. So I should thank all the speakers coming all the way and making very successful. You can see it's a full house symposium. So it's a current trend in the management of diabetes. I should thank the kind sponsors, Boringa. I think after learning about the diabetes, you can have a big meal now. So please collect your meal and go. So may I ask another small announcement? KSN is going to have a family concert, and Ranmini Vijayakon is the one looking after that. On 10th of December, please try to join and make it a fun event. And please join that event too. We will be sending details as well via WhatsApp. May I ask Dr. Tamara Kannankar to come forward and give the certificate of appreciations to the speakers today. So, Nishan Ravidu, Senior Registrar in Nephrology.